Case history was a 54-year male, history of unstable angina, smoker with history of COPD, non-diabetic, ECG sinus rhythm, STT dynamic change, some typing mistake, propine negative, echo no RWMA, ejection fraction 55%. This is the angio. There is a significant lesion in the mid LED. RC and L6 was normal. Meanwhile, patient complaining chest pain, then with the LED was 100% occluded. CTVS department is informed, but all the table of CTVS department is booked. And then we start to bail out the procedure. Then we tried to balloon trapping with the multiple wire as per previous case. Then we remove the balloon in the guide, and the whole assembly is pulled down up to the iliac artery. Then take the another access. Then we took the shoot. Then taken another decision with the rotablation did that place. Then we did the angioplasty, PCI to LED. Mid and proximal to stent are then finally a TIMI third flow and good result. Then balloon snared from opposite side after the PCI with the snare. This is a snaring video, and this is a photo of the balloon and shaft. The take-home message: angiography looking simple lesion, sometimes very challenging. Do not pull hardware when hardware stuck. Do not panic and think for option as a primary operator. Multiple guide wire technique can be used for balloon interment, and need opinion rotational atherectomy in the dissected lesion.
So very similar to the last case. Any comments from the panel? Any comments from the audience?
I could see a second guide being put. Why was that guide put? You are worried about the vessel getting closed. Can you go back? So sometimes vessel gets dissected and you are worried the vessel will close down when you pull back. So he has used a ping pong guide. I think like one more guide is been seen. Go prior to this. Back. When you are trying to pull out before this. After this. Go next. Go next. Next.
Sir, what you want to see is prior to this. You have to go back.
Yeah. There are two guides which were seen.
I think he changed from radial to femoral. That's it. From 6 French to 7 French.
But you are doing the radial procedure first.
So I think this is what epitomizes rota regret. Ab initio, what we probably did not miss. We missed the calcium. We did not image. And
Actually, patient complaining chest pain and not other facility. We try to finish as soon as possible. We trying to finish the procedure as soon as possible.
Yeah. So firstly, Florent wants to say something.
Just as an advice, if you do this into a calcified lesion, you inflate the balloon does duck boning, or sometimes with a stent. Very often you come into a panic and then you want to pull out the balloon. That's the wrong reflex. You should say, okay, it doesn't inflate. I think I need something different. You deflate and you wait, and you wait, and you wait, and you wait a bit more, and then you gently pull out the balloon, because otherwise exactly this happens, and then you are in deep trouble. So this is avoidable if you just give it a bit more time before you take out the balloon.
And in fact, don't even pull, just push it in, and then retract it. It's back to the same as the last case where you get a fracture in the shaft because you retracted too early. The balloon's fixed, the guide interacts with the balloon, you crack the shaft, you know, and then and I think it is going to be more likely when you're reusing equipment, because it happens in equipment which is fresh. It just is what it is.
What was the size of the trapping balloon?
Trapping balloon, 210.
That's the problem. Sometimes, using a bigger size, like at least a 2.7 is really small. And it's happened with all of
It
us.
depends on the guide catheter. So depending on who's your trapping balloon for any trap.
2.5 works actually.
But
Yeah,
your
2.5.
last question which you made, can you perform a rotational atherectomy in the presence of a dissection?
Yes.
The answer is yes, yes, and yes. You just have to be more careful. Because in the days gone past, we all had cases where we had dissection flaps, we have cut with DCAs, and we've actually done rotational atherectomy to get through those dissection flaps and then had better results. And the times that we didn't even have probably stents around. So in those days, I'm just talking about, I'm reminded of that time. But that's a good pertinent question, because it might be a question in everybody's mind.
Thank you.
Brilliant. Thank you for that.